Thank you for staying on The Baby Doctor. Today, like I said, we will be treating the condition jaundice. We'll be looking at what causes it and what the remedies are. And I've been joined today by Dr. Christine Osei-Yeboah. We love to call her Dr. Coy because that's like, you know, friendly and exciting because she's a pediatrician, a consultant pediatrician and a public health specialist. And today she'll be helping us delve into this issue. She's with Coy Pediatrics located in Tema. Doc, it's a pleasure to have you here today. And thank you so much for agreeing to have this very important conversation with us. And I see that you're wearing your yellow hair, yellow month shirt. Basically tell us about why this is important and why the Pediatric Society of Ghana is embarking on this campaign. Then we'll zoom into the conversation.
Okay, thank you, Bernice. And I must say I'm happy to be here. Yes, why are we dedicating a whole month to talk about neonatal jaundice? It's simply because if it is missed, the effects are fatal, and most of the damage caused cannot be reversed. But then it is avoidable. No child needs to go through that process. And so that's why we believe that with the right knowledge and the right interventions at the right time, every child will be spared the damage that they get from neonatal jaundice. The jaundice, the damage affects the brain, and it is permanent. And so the child has a lot more disabilities than he ever bargained for, and nothing can be done to reverse them. What we are able to do is to just help the child manage the disability, but that we think that is an unnecessary harm done to a child who was hitherto born well.
So Doc, what is neonatal jaundice?
Neonatal jaundice. Okay, neonate is a child, a newborn. So a baby born in the first month of life, we call you a neonate.
Okay.
Good. Jaundice, Jean or jaune, that's the French word for yellow. Oh. Yes, so a yellow baby is neonatal jaundice.
Basically.
And so when we say the baby is yellow, it means that the skin and then the eyes, or let's say the mucosa, that's if you look in the mouth, it looks yellow because we are dark skinned. So sometimes you can miss it. But when we say somebody is yellow, that's jaundice. The person's eyes have turned yellow. The skin is looking more yellow than it should be. The person is jaundiced. Simple.
Yes. So in my introduction, I shared some statistics. 8 out of 10 preterm babies,
yes.
And 6 out of 10 term babies end up having jaundice. What causes it?
Okay, it is caused by some changes that happen when a child is born. And so to put it in context, let me start from when the child is in the mother's womb.
Okay.
When the child is in the mother's womb, he needs a lot more of red blood cells. That's the blood cells that the cells in the blood that carries oxygen to the brain and to every part of our body. We all use our red blood cells to make sure we get enough oxygen to the different parts of our body. And so that's what happens to a newborn. Because he's drawing from mommy in the womb, he needs a lot more.
Okay.
But when baby comes on earth and his lungs begin to work, then he doesn't need that much HB or red blood.
Right.
And so the body begins to break down the excess so that he doesn't have more than necessary.
Right.
When the body breaks down the red cells, there's a part of it we call the heme. And when it breaks down, then we form the bilirubin. The bilirubin is the yellow ones that give you your skin color. And when normally the body breaks down the heme, the bilirubin is held by some boys or a mother called mother plasma.
Okay.
And she holds the child bilirubin as they walk in the blood cells and take them to the liver to deal with it so that it comes out in our urine, in our poop, in a form that is not harmful.
Okay.
When a baby is born and is producing a lot more heme, then we have so many bilirubin, so mama plasma has not got enough hands to hold on to all the baby bilirubins. So some of the baby bilirubins are let loose and they start loitering around the street, gallivanting the street of the bloodstream. And then they decide to stray. So when a lot of them are there, you know, when children get adventurous, so they come up with the idea of going to places, and they end up in the brain of the child. When it gets into the brain of the child, it goes to destroy the cells in the brain, and that is permanent. And so that is what happens in neonatal jaundice. It's the bilirubin that is in excess, and the liver cells who are also now maturing, and so are now working hard to get rid. So you have this excess loitering around. Also, at the same time, we know that when the liver breaks down the bilirubin, they have to come out in the poo-poo or the urine. When a baby is born and he's not feeding well to poo-poo, then they stay in the gut for longer. Okay. And then they begin to go back into the bloodstream. Yes. Oh. We call it, I don't want to use big names, but then, yes, so I think I'll leave it out. But some go back into the bloodstream, and then they break them down again. And so basically that's what happens in the first week of life. And that is always the tricky part of life. Subsequently, the brain gets mature, so it doesn't allow little boys to stray into the brain. And then also the liver matures, and so then
it can break it down.
It can take care of the bilirubin boys and girls, and they don't get any naughty work to do. Okay. So in a nutshell, that's what happens.
Right. So we understand that there are different types of jaundice. You've just basically told us why it happens and what causes us to see the yellow pigmentations in the eye and on the skin and sometimes in the mouth. But what are the types, and how do you handle the types of jaundice?
Okay. For the medical person, we may give it different jargons. But then for everybody, I think we can group them into the physiologic. Okay. And then the pathologic. Pathology means disease. Okay. Physiology means a normal happening in life. So we have the physiologic and the pathologic. The pathologic can be direct and indirect. I'm sure that's the word you wanted to hear. Yes. So the physiologic is predominantly indirect, but even under the indirect, we have the physiologic and then the pathologic. And under pathology, you can have indirect and the direct. The indirect ones have a lot of bilirubin floating around. The direct ones, we call those bilirubins unconjugated. They have not been touched. And then the conjugated ones are the bilirubin that has gone through the liver, has undergone necessary changes, but there's a problem. Okay. And so sometimes it's because the gateway for the one that has been changed to go out of the body is blocked. And so you will have extra bilirubin, but it's conjugated in the bloodstream. Okay. Because when they were changed, they could not go out. Okay. So I think in simple terms, that is it. But then what I think is of interest to listeners is that the pathologic is any of the jaundice that we put under pathologic is problematic. Okay. And the physiologic, which is not problematic, is a diagnosis of exclusion. So we have to confirm or convince ourselves that this yellow eyes we are seeing is not pathologic. There is no disease process underlying it. Okay. And when we have convinced ourselves of that, and the level won't harm anybody or will not have enough of the bilirubin boys going to the brain, then we say physiologic. And that normally will clear within a week. Okay. Yes. Even with or without any intervention. But you cannot tell from a child's face that this one is physiologic, that is pathologic. So that's why we are changing the narrative, that just go to the hospital and let a doctor convince him or herself that it is not pathologic. Then you can go home and wait for your baby's eyes to get white again.
Right. So basically, I think what we are learning from Doc is that you and I cannot detect what is causing the yellow we see in the eyes of the child. And so you must get a health professional to check that child and give you the all clear that everything is fine. And the early detection is what Doc is preaching here. And the Pediatric Society of Ghana is preaching the same by extension. Get your child checked. Doc, in the first week of birth, it is important?
Yes, it is super important. And so if I will share with our mothers, my personal philosophy is from day one, learn to blanch the nose of your child. Press the bridge of the nose.
Yeah.
The tip of the nose, not the tip.
The tip,
and look at the color.
Okay.
It
From
will,
the first day?
From day one. It will look very pinkish. Day two, come out of the room, check again. If you see that that color is changing, then your baby may be getting jaundiced. So you need to send the child to the hospital for the doctor or the midwife to check. In the past, when we were staying in hospital for days before we went home, it was okay because the nurses will come around in the morning and check, the doctor will come. But now you deliver in the morning and by evening you are home. And we know that a lot of these jaundice occur within the first 3 days of life.
Okay.
And so it's in your interest as a new mother to check from day one, and so that you can see whether there's any difference. And please don't keep your child indoors. Step out, come to the porch.
Into the open.
Into the open, I mean, or draw your curtains.
Okay.
So that you can see, because the day you gave birth, you saw your baby's face, and then you press. So the second day when you check, you can always tell when there is a difference.
So, Doc, you're
Yes.
saying that it's always best to check or do the test on the nose in a clearly lit
Yes.
place, preferably
Outside.
outside.
Preferably outside. And the good thing is now, many of us are in gated homes. And so...
But they say, though, you know, sometimes you see the tradition must go on.
I know.
When you have a child,
no evil eye should see the child.
exactly, you're told that you need to keep the child at least for a week, then you outdoor. That is the actual outdooring. Right now, because of modernity and all, people are, you know, shelving the outdooring for naming ceremonies where some can even do it 3 months after the child is born.
Yeah, when the child is sitting.
But we are told that traditionally the child is outdoored on the 7th day.
Yes, which was true. I think then they were trying to outdooring meant others came to see the child.
Okay, not
Others held
necessarily the child going
out.
outdoors.
Yes.
Okay.
So outdoor, you were in a compound house. If you came out of the room with a baby, everybody will come and see the baby, whether it's a boy or a girl, and congratulate you. And that came with the challenge of infections and other things. But I think stepping out, now we know better. It's heart-rending when you see a child coming after days of being so jaundiced, and you know that so much harm has already been done. So I think for our new dispensation, there is wisdom in stepping out every day to at least check. It doesn't mean go around the whole neighborhood showing off your new baby, but then you should come out and make sure that your baby is well. Yes.
Right. So, Doc, I mean, I want to believe there's absolutely no way a child can be jaundiced without presenting the yellow pigmentation, right? So,
Yes.
So then, I mean, these are the ways you can detect. Are there other ways beyond that?
No, jaundice is yellow, yellow skin. So
Right.
if there's no yellow, then
the
there's no
child is not
jaundice.
jaundiced.
But then we know that when there's yellow, then sometimes the poo-poo may give us some idea of which type of jaundice we are dealing with.
Okay.
But for us, for me, I think for the new mothers, the key thing is that when you see the color, move and leave the other decisions for the health worker. But then you should take note of the poo-poo color. If we go and the poo-poo is all pale and white, then we are looking at direct that we talked about, yes. And if it's all the normal baby poo-poo, then we know that, okay, it may be indirect. So it guides us. So when you go to the hospital, those pieces of information are useful to the health care provider. But then it is not for a mother at home to look at poo-poo color and decide that this is a no problem jaundice, so let me keep the child at home. Because you may be sitting on a time bomb. Yes.
Doc, you said something interesting about our skin complexion and why, because some of us are very dark in complexion, the skin alone may not give you the signals, as in so clearly enough.
Well, yes, but then for a baby, most babies are fair colored.
Yeah.
And so if you press the tip of the nose, the normal pigment color goes away, and you see a light color tone underneath.
Okay.
Correct. So when you press on it and that color is pinkish, then you know there's no jaundice. But when you press on it and it's looking yellowish, then you know that there is a problem. Yes.
Doc, let me go back to tradition, because in some places you're told, oh, this is Nkolayare. You know, with the statistics we shared, it's quite a common thing. Obviously, you've given us the reasons why, coming from prenatal circumstances into even the development of the liver and all that. And some will say, oh, Ebeko, this is not as yellow as. Should we be looking for grades of yellow, or once we see yellow, we should move?
Yes, I think from what we see in the hospitals, the person the one who is not a health worker like you, is not your best judge.
Okay.
Good. And we also know that we are racing against time. The first week of life is the key period. And so as they are saying, give it a few days, you are delaying. And the bilirubin boys and girls are loitering around, and you don't know how many there are. And so we say, when you see the change in color, move. You don't need to see it as deep, because the deeper it gets, the worse. And normally by the time the color goes to, it starts from the face, I must say. It starts from the face, then it moves to the chest. And so when it starts from the face, the level is lower. When it gets to the chest, we say moderate. When the feet and hands are all yellow, we say it's serious. Yes. And so that's why I said the nose. Yes, I didn't say the chest. I didn't say the hands. The knees, because by the time you see it in the palms and the sole of the feet, it's gone past normal levels, and it's in dangerous levels. And that's when the likelihood that the naughty boys and girls will go into the brain is higher. So I say, most of the time, those who listen to the relatively adults in the house tend to present to the hospital very late. Mind you, they say it's nothing, but when you have side effects from it, they are not there to support you through it. And so I think it's better to waste a little money to be assured that your baby is fine than to just believe everything everybody says and have a lot of problems later. We have grown. Medicine has evolved. Now we know better. And so now we don't even put the child in the sun as we used to. Yes.
You're going ahead of me, Doc. We'll come to the sun matter, because that's also one that we must discuss. So just to clarify here, the side effects or the damage the excess bilirubin causes, which is what makes it look yellow, is not dependent on whether it is physiological or pathological, right? So, because we started the foundation, we say the physiological is not a disease. I just want us to clarify that so that mothers and caregivers can understand that even if it is physiological, if you do not go to the hospital early enough, it can cause some damage to the child.
It depends, but you wouldn't know it's physiological or not.
Okay.
So that's where the issue is. But most physiological jaundice with the right interventions will not cause damage.
Okay.
So normally when it's physiological, it's because the breakdown is fast, and then maybe the child is not feeding enough, mommy is not getting enough. And so as soon as you address the feeding problem, you flush out the jaundice. And we would have checked the levels and seen whether there are few times that the physiological may have such high levels. And so then we will put the child under light. But if we check, and then the rate of increase in the bilirubin in the blood tells us it's okay. So the doctors look at so many parameters, not just the skin color. We will take a blood sample, and then we'll say we'll repeat the following day. And it's because we want to see whether this is something we should worry about, or this is the type that we can encourage mommy to just go and feed and come home. And so in the past, when there's no cause for alarm, then they will talk about sunbath. But because people are abusing sunbath, Now we don't even talk about sunbath because we have a more sophisticated form of the sun in the hospitals to use for the babies.
Which is the physiotherapy?
That is the phototherapy.
The
phototherapy. So light treatment.
Okay.
Therapy.
Interesting. Doc, is there anything a mother can do at the prenatal stage to help prevent jaundice in a child? Is there anything? Has science determined that?
There are a few things that mothers can do to help their babies. And I will list them as such. The first thing is during antenatal, make sure that they've checked your blood group and then also your husband's blood group, because we know there are causes for the pathological one. One of them is the blood group incompatibility. So if your blood group is O and your husband is anything apart from O, then we know that there could be a likelihood that your child, there will be a fight between the blood groups. And then also check your Jaundice PD status.
As a mother?
As a mother. Because we know that it tends to be inherited from mothers. So if you are going to antenatal, make sure these tests are done. I know in the traditional hospitals they do them, but sometimes because we go to all different places for our antenatal and we are always busy and running late, we may miss some of these tests, but it is important. And even when you've done it and they've written it in your book, make sure you know what it is so that you are also educated on it as a mother. Yes, so that's one of it. The second thing is, let's avoid camphor. Jaundice PD is common in our environment. And we realize that camphor it triggers the reaction. And so the Jaundice PD is a protector of the red cell.
Okay.
So when you don't have some, or you have very little, then your red cell is not well protected from some shocks. Good. And camphor is a #1 shock. So we get children who are getting pathologic jaundice because parents have put camphor in everything because it's got a nice smell. So even before baby arrives, we've packed the things, we've put balls of camphor in it to keep all sorts of reptiles. And
they even sell them in baby shops.
Shops, yes. And so that is one important thing that every mother can do to protect the child.
Okay.
And with that, you save your child pathologic jaundice.
Wow. We are learning something yes. Today. Please keep the camphor away from children. I mean, it's not helping them, as Doc has highlighted.
In fact, camphor should not be in the house.
Oh, really?
Yes, for a baby. It shouldn't be in the baby's room. Keep
Once
it away.
Babies,
keep it away. When they are older and you know that they don't have any problem with camphor, then you can, because the problem with the camphor is more than the benefits you derive when you have a baby and you have camphor in every corner of the house. You know, sometimes even the bathing bowls have camphor, the drains have camphor.
Everything.
No, let them go. Let them go till you are sure you don't have a problem.
Doc, I'm sure there are a lot of questions on people's minds. I hope that we can address them by the time the conversation is over. We hear of so many things when it comes to jaundice. You've mentioned some of them in passing, but I want us to be very emphatic in determining whether it is a truth or not. And one of them is that jaundice will correct with time. Is that a statement of fact, or it depends on what we are talking about here?
It is not a statement of fact. It depends on what you are talking about here. Physiological, clear.
Okay.
All the others need intervention.
What kind of interventions? Medication or phototherapy as well?
It depends. If it's indirect, then it's phototherapy. If it is direct, then we have to know the reason for the direct and correct the problem. Okay. So if it's a liver disease, we have to treat the liver.
No, babies at that stage can have liver disease?
Yes, babies can be born with it. And babies can be born with the bile duct. They are born and they don't have a bile duct, or they have a blocked bile duct. Oh. And so, you know, I talked about it's processed, but it can't come out. Yes, so we have to find out what is the cause of the jaundice. Then we can say that it will end with time. Yes, many will end with time, but what effects do they leave in their trail is the problem. So you cannot be jaundice forever, but then
what will it leave you with?
What will it leave you with, and or where will it take you? Because it can take you to your grave too, if you ignore it. Yes, if it's severe and the cause is ignored, it can take you to the grave. So it's either it's leaving you with a lot of bad memories, or it's taking you to an early grave. Yes.
You've spoken about the side effects, especially when in the first week they manage to go into the brain, where you say that the brain's gate is not developed. I like the way you create a mental picture for all of us so that it's easy for us to understand. What are some of these side effects? How do they present? What will the child end up with?
The child will end up with where it causes the most harm is the base of the brain. That is where the cells for balance, the cells for movement, for hearing, for walking, stability is. And so you get a child who will be delayed in attaining all these milestones. They may walk, but they are not stable. I have one patient who walks and he keeps more or less twisting and turning with every step he takes. And it is the effect of neonatal jaundice. Yes, because he had neonatal jaundice as a child. But apart from that, he's fine. But when he's walking, he's staggering and everybody's turning to look at him. And nothing can be done to reverse it. Some too never walk. Some too, it destroys their hearing so they can't hear. Or they are drooling all the time. They are not able to hold saliva together. Yes, so it comes with a lot of stigmata. Yes. And then in some cases, it affects the higher brain development. So the child doesn't do well in school. If you are not sitting, and then sometimes they cannot speak because it's affected the muscles of the fine muscles. So they are speaking in a slurred manner, or they are speaking and you cannot hear clearly what they are saying, and their mouth is drooling and they are rotating, twisting. So at the end of the day, do they even get the opportunity to be in the regular school like every other child? Not all the time. And do they have the kind of support that they need to bring out the talents in them? In the environment, we know how limited that kind of support is. And so if you can spare your child and yourself that pain, I think it's worth sparing yourself.
And Doc, at these interventions, you spoke about phototherapy and in some cases having to give the child medication. Are they expensive, or are they readily available anywhere in the country?
Actually, yes, they are available. Now we have a lot more phototherapy units in Ghana. But I must say, when I was training, we used to get the bulbs, a particular type of bulb, and create our own. We get a carpenter and make the wood. And so the phototherapy is the least expensive treatment. Meanwhile, the effects are just beautiful. And so leave the clinician. If you go to any facility when they don't have phototherapy unit and tell you that we'll be doing sunbath, please go to another facility.
Okay, they'll be doing sunbath.
Yes, you put a child in the sun. I will recommend you go to another facility because they are behind time. And you are better off going to another facility and getting your child the needed help. If you go and they confirm there's no cause for alarm and you want to come back home and do sunbath so that the jaundice will go faster, fine. But do not put breast milk in the ice and do sunbath. Whoever gives those options are way behind time, and they may cause you pain in future. So that's what I would say. Yes.
I don't know why when it comes to babies and mothers and pregnancy, there are all these myths and all these ideas about how you can deal with them apart from seeing a healthcare provider. Because I also heard a bit about putting milk in the baby's eyes, and I asked myself, how is that going to solve the problem?
It's a good question. I take it that, we always want to be seen to be doing something. And so that's what people try to do something about the situation. And mind you, many of the physiologic ones would clear. So by the time they do their co-minini by day 3, is clearing and they think the co-minini has done the trick. But the co-minini didn't do anything. It's just that God saved you because it was nothing serious. Because we know that a good percentage of these children is nothing serious. Yes. So I think that that's the best explanation I have been able to put to all those maneuvers that we put in. Because the key thing for me is to feed the baby well and make sure that you are maybe topping up with express breast milk and then seek help and let's make sure that the baby is fine. If you come and it's just on the tip of the nose on day 3, baby is feeding well, baby is fine, the health worker knows that there's no cause for alarm. Or he will take the blood sample. The results comes, it's so low, you don't have to worry about. Then we will assure you and send you home. But then you have your peace of mind. And then you are also assured that you will not have any effects when the child is growing up. But assuming the doctor at home, with all the knowledge, paramedics you have who are as good as yourself, does not help your child in any way. And most of the paramedics cannot be sent to any institution to be punished because they were trained and graduated at home.
From in their own kitchens and
the certificate was given at home, so there's no governing body to report to. So I think we should just be careful and let's protect our children.
Right.
Yes, a little waste of money in code for a blood test is worth it.
It is worth it.
It is worth it.
We'll take a sip of water now, but when we come back, you know, we always try to get interactive with you to pick what's happening on the ground, real life issues, and get our doctors to respond to them. So Doc and I will be doing that right after these messages. Thank you so much for staying on The Baby Doctor with me, Bernice Abu-Baidoo Lansah. Today, I'm having a conversation with Dr. Coy, and we're talking about neonatal jaundice. I hope you have learned a lot, and please don't keep the information to yourself. This is information that you have to share with everybody because, you know, it's important. As we say in Ghana, it's a community that raises a child, and so when we all know these things together, we can help out a mother and save a child from having lifelong side effects of neonatal jaundice. I told you just before we took that breather that we were going to get a bit personal, share personalized stories and get Doc to respond to them. So Doc, let me start with one where this young mother rushes into the neonatal intensive care unit of the Komfanochi Teaching Hospital with a baby that is looking as yellow as the shirt you're wearing. That is the most yellow I have seen a child. I panicked. The nurses were surprised that this mother had waited so long to bring the child and said, why did you keep the child till the child got this yellow? But here's where my question comes in. So the doctor meets the woman and says, we would have to drain the blood in the child and replace the child's blood with yours. But even there, we are not sure if that will solve the problem entirely. We need to run a few tests to ensure that we're given the right medications and interventions. What exactly is happening here?
What is happening is the child has come at a late stage of neonatal jaundice. You know, I told you that it graduates. And so he's so yellow that the bilirubin boys and girls are all over the place. And our worry is that if we leave that child's blood as it is, there's so much bilirubin boys and girls, they will go into the brain.
And they can't pass out?
No, we've gotten to a level that we can't wait, because the truth of the matter, by the time she arrived, we didn't even know how much damage has already happened to the brain.
Right.
And for that damage, it's only time that tells. And so the doctors and the nurses' main task was that let's get as much of the bilirubin-infested blood out and give this child blood that hasn't got bilirubin and reduce the concentration of the bilirubin.
Okay.
Good. So that's what they were. So we call it the exchange blood transfusion. We draw some of yours out, then we push in the new one. We draw some out so that we are hoping that if the bilirubin concentration was like, say, 5,000, by the time we are done, we would have reduced it to 200.
Okay.
Or 250. And then 500 and 250 500 are more likely to cause more damage than 250. But they said they were not sure because there are so many other parameters that will come into play. If the other causes of jaundice that I didn't mention, some could be from infection. I talked about mother's blood group, yes. So if there's the blood group incompatibility, they are hoping that the reaction, because what happens is that if mommy has the antibodies, the soldiers in mommy have gone into baby and are attacking all the baby's cells. They are seeing them as enemies of progress. So what we are doing is that we are reducing the volume of the enemies of progress in the baby and putting in normal ones.
Soldiers.
Yes, and hoping that they will stop beating because they are not enemies of progress, so to speak. And then also an infection can cause the breaking down of the red cells. And so in that case, whilst we treat the infection, we know that the jaundice levels will reduce. Yes. But the key thing is to reduce the concentration of the bilirubin, boys and girls. And then normally after the exchange blood transfusion, we put you under the photolight. So you will still do phototherapy. But we know that when you go beyond some level, the risk of brain damage is high. And so their interest is to make sure that this child does not stay in that high level for a long time so that we save what is left of the child's brain.
Do you record fatalities in jaundice?
Yes, we do. So that yellow baby may either pull through with side effects or may die. It's one of two. And so I'm sure you saw how they were all alarmed and they all reacted. They're like, oh my God, how could you do this to your child? Yes, so we record fatalities. You can do all the exchange and everything, the child will still pass on. Yes, and sometimes when there's so much damage, the child may be better off going back to the maker because the quality of life later on is stressful. It's stressful.
So there are two questions here. It's about whether or not this woman had enough information on what to do and what to look out for, or it was just a sheer case of negligence. In your practice, what do you see to be the issue when it comes to delayed reports to the hospital when it comes to jaundice? Is it a case of lack of knowledge or sheer negligence?
I wouldn't say sheer negligence. I think it would be unfair to say that because after 9 months of carrying a baby, you had enough time not to do the child any good if you didn't want this child that bad. And so it's more of lack of knowledge and misinformation.
Okay.
It's lack of knowledge and then misinformation. And you know, in our setting, the decision makers most of the time is not the mother of the newborn. It's the grandmother, the auntie, the mother-in-law, the retired health worker who is supposed to be all-knowing but may not have been that, because you know in our space, every woman who works in the hospital is a nurse.
Auntie nurse.
Yes, so even sometimes the person may have been at the records, but he's a nurse. And she will also be bold enough to give an opinion when she has no clue what is happening. So I think it's more of lack of knowledge and people don't know. And so even when you say the child is looking yellow, she's never seen a newborn. She doesn't know what a yellow baby looks like. So she sees the child as yellow as what you are describing, like my t-shirt. Then even the almost blind will know that this is not a normal color. But by this time, it's late. So the most mothers don't even know how to look for the jaundice. And that's why we've been spending time educating people that they should look. And that's why I personally say from day one, so that you have a clean a marking scheme.
Yeah.
And then you can compare. Because if I tell you day 3, press and see, you don't know what day 1 look like. So how will I know the difference in day 3? And so from my experience, I have decided that day 1 is, I think, the marking scheme. And then day 2. There are a few children who will start getting jaundice on day 1. That one is pathologic straight away. But then you would most of the time be in hospital. So the health worker would have seen. Yes. If you are going home, you see a discoloration of the child's eye, you draw whoever is there's attention. You say, oh, it doesn't matter, go home. And it's in the first 2 days of life, please don't go home. Insist on a second opinion. because you may end up coming back with a sad story. So if you see it, maybe opens that it doesn't look white day one, and whoever is discharging says you go home and feed, please don't go. If they insist that they don't want to keep you in their hospital, go to another facility, because somebody has to do something else.
Okay.
Thank you.
Go home and feed brings me to my next personal story. And this is a story I saw on social media, where a mother is talking about how she believes her child developed jaundice because he wasn't getting enough breast milk. And in my reading, I've also come across breastfeeding jaundice. So I don't know if it's the same thing, but what is the correlation between breastfeeding or feeding, the amount of food a child is getting, and jaundice?
Good question. One, let me answer this question this way. Breastfeeding jaundice is not common.
Okay.
So it's only a few exceptional cases, and it's actually a diagnosis of exclusion. You've done everything, you realize that, and for those breastfeeding jaundice, it doesn't cause harm to the brain. But then, new mothers normally don't have plenty breast milk. Some are also struggling to put the baby to the breast. And so that's where I have a challenge. We tell the mother, put your breast in the child's mouth. She has no clue what she's doing. She tries to do something to represent breastfeeding, and then they go home. And so she's not able to feed. And we know that I said that if the bilirubin stays in, if the poo-poo stays in the gut for a long time,
Goes back. Recycling.
Recycling. And poo-poo is not coming out for the bowel to pass out. And when you are not feeding the child gets dehydrated. Dehydration also makes jaundice worse. Okay? So that's where the problem is. People are not establishing feeds in a timely manner so that the gut bacteria will start working and get rid of the contraband. And then it becomes a vicious cycle, and the baby gets more yellow. And so as soon as you put that baby under the light, get the child to get enough feeds to flush out, within 24, 48 hours, baby is fine.
Okay.
Yeah, so that's where the feeding problem. So it's more of problems with feeding, which is making the jaundice worse, as against breastfeeding jaundice. Breastfeeding jaundice happens, yes, but it's in a few cases. It's in a few cases. And that one, some enzymes misbehave, so. But most of the time, even for the breastfeeding jaundice, when you continue, it clears.
Interesting. If you just joined us today, we are talking about neonatal jaundice, and a very, very important subject. Doc has clearly established why it happens and, unfortunately, the irreversible effects of jaundice here. So please, you want to spread the message and catch a repeat broadcast of this program if you missed it from the beginning, because this is knowledge that you should acquire. It will help you and help another person. So, Doc, what's the big dream for the Pediatric Society of Ghana? Every year you create awareness in the month of May about jaundice. What is the goal? What is that one thing that you are looking forward to in the coming years as you continue this campaign?
Our biggest dream is to make sure that no child suffers any side effects from neonatal jaundice, and that every child whose eyes get yellow gets seen and is protected from any negative side effects of jaundice. So that's our biggest dream. No child should have any side effects from jaundice because it's preventable.
Right. It's now time for us to share our tips with you for today, and once we're done with that, we'll be back to give you the important information you need to know about COI Pediatric. Hope you kept those notes, vital information for you to keep and help somebody or help your child out when it comes to the issue of jaundice. I've still got Dr. Koi with us, and Doc, before you go, you've been doing this for how many years, taking care of babies and children?
For more than 2 decades.
Wow.
Yes, for more than 2 decades. Practicing medicine is 3 decades, almost. But for pediatrics, yes. And COI Pediatrics is 15 years this year. Yes, it started as a small afternoon clinic, but serious business 10 years. And COI has grown from a small facility into a big facility. We have two clinics now, which run 24-hour service for children. Yes, and there's always a doctor in COI at any time to take care of your child. So that's what we do now. And then we have laboratory services at each location. And even on Sunday, our labs are open till 8 p.m. So when you walk into COI, you don't even need an appointment to enter. If you call the number and you can't get through, just walk into the building and you'll be taken care of. So COI provides regular pediatric services for children from 0 to 18 years. So till you are able to vote, you qualify to come to COI. As soon as you get a voting right, then we graduate you. Yes, and then you qualify to bring your child, but not yourself. And we provide clinical services and also support services. So we do all the therapies, behavior therapy, occupational therapy, speech therapy. Yes, so any delays in the child, we have the therapists who provide services at both facilities. We have a neurodevelopmental pediatrician who will come and assess your child. And so that is additional services that we have. And then also physiotherapy, additional, and then also a dietetic service. So these are additional because we realize that the child's well-being is supposed to be holistic. It's not just managing fever. Yes, so,
I like that.
Yes. So we've provided these services. And then we also have a community health wing of COI where we go into schools and provide school health services. And the rationale is that we know that the average Ghanaian doesn't go to hospital for regular checkup. So the children are always left behind. So we develop this protocol where we go into schools, examine the children, but we don't draw blood in schools when parents are not there. And then if there are any comments, we send a note to every parent. Good challenge, every child gets a paper. In the past, some will get, and the question is, why did you not get? So now everybody gets, and it's good. It's been interesting to be able to monitor the children annually. And when they leave this, when they graduate, we have made a little book now. And so we are able to tell whether you are growing too big, too fast, or you are not growing as you should. Or we saw a problem, we referred you to you. And you don't have to come to COI because we've seen a child's problem, but the key thing is the child should be taken care of by the doctor. And we've seen children with heart problems, with eye problems, interesting challenges that have been corrected because we went into the schools to do the school screening. And then also for new joiners who are going to school, they ask you to do your medicals. We will do the vision, do hearing, everything to make sure that when that child goes to school, he's able to compete like his peers. Because if you are sitting in class and you can't hear the teacher well, then God help you.
Then that's a problem.
Yes, and it's not fair. The child is not being given a fair chance, so he will be unhappy in school and nobody knows what his problems are. And sometimes we find out a bit too late. And so that's why we do the community health wing. Of course, we do education. It's one of them. Go to organized groups and educate them, churches. And a few times we have fun. We do fun games, yes. So in August, we're actually going to have a family fun day. Yes,
kids are always fun, aren't they?
They are fun. And we create the opportunity for them to have fun and still get checked. So they get a dental, everything, and then they are good to go. So that's a bit about what we are doing so far.
Thank you so much, Dr. COI, and thank you for doing the watching today. We really appreciate your company. You can locate COI Pediatrics with a simple Google search. You can find their contact and location. That'll be it for this edition of The Baby Doctor with me, Bernice Abu-Baidoo Lansah. Let me say a very big thank you to Azel Vogue for my beautiful dress. You can find Azel Vogue on Instagram, and the contacts are also there for you. And you can call them, and they've got you covered with all or for all your fashion needs. Catch you again on another edition of The Baby Doctor. Take care.